So let's talk about patients who are failing their first-line therapies and are now on steroids. First of all, how do you taper steroids? It's a simple question and everyone does it, but do you have an approach that you have systematized or that you think of, or what do you do to taper your steroids? Russ?
Well, if you have someone on another therapy to which you're going to bridge them with the steroids, that may impact how you're going to taper them. So for example, if you're tapering them to a slower acting agent, such as azathioprine or 6-mercaptopurine, then you actually may taper a little more slowly to allow the other agent time to work. However, if you're just getting someone through a flare and you think that whatever medicine they're on beforehand, that'll keep them afterwards, then you might go more rapidly. So often we say when someone has a flare that requires steroids, they use 40 milligrams of prednisone, perhaps in divided doses, and then taper them by 10 milligrams a week, maybe slower as they get to the lower doses. But again, it really is going to depend on the patient, on their previous response to steroids if they've had it, on their current response and side effects of the steroids, and what your game plan is later on.
Steve, do you have a different approach?
Well, first of all, it's a great question because it's the one that there is absolutely no evidence in the literature regarding that. In some clinical trials looking at steroid-sparing agents, there have been regimens along the lines that Russ said, that initially you can taper by 10 milligrams a week, maybe down to 20 milligrams, and then 5 milligrams down to 10, and then slower. But we really don't have one algorithm. In my experience, I look at how long it took them to get under control and taper kind of based on that. If they respond immediately, taper quickly. But if they took, and of course, considering what you're using to maintain the response.
I want to emphasize one point you made, which is there's really no evidence here. And people tend to taper steroids slowly when they're fearful of a rebound effect, which could be seen in such diseases like psoriasis, but hasn't really been described in IBD. And the other area and reason people think about this has to do with adrenal insufficiency. I spoke to our endocrinologists a few years ago when I'd been invited to give a talk on this topic, and they said that 2 weeks of steroids doesn't need a taper. So if you had a reason to use it and you had another therapy on board or you had a plan otherwise, you don't even necessarily need to taper with that. So I learned a lot when I talked to them, but I also learned that they didn't have any good evidence either. So when you're ready to move on to something else, one of the major topics in our field has become, do thiopurines still have a role in managing our patients with Crohn's and UC? Let's talk about ulcerative colitis specifically here. Are you still using thiopurines to manage your ulcerative colitis patients who have needed steroids?
Yes. I also want to speak to, along those lines, to the two concepts of steroid dependence, as you mentioned, and steroid refractory. And get our descriptions clear. A steroid-dependent patient is someone who can't taper, but starts in remission. A steroid refractory patient is someone who's having symptoms despite being on them.
Yes.
So the approach is somewhat different. I go back to my basics, and one of the basics of ulcerative colitis or even Crohn's is the first thing you have to do is induce remission. You can't maintain what you haven't induced. So if a patient is still sick, you can't go on to maintenance therapy until you get them completely well. So you have to get them into as close a remission as you can, and we'll discuss that later, I'm sure. Personally, I still believe in thiopurines. We've used them for 40 years. There's evidence in both ulcerative colitis and Crohn's disease that they can maintain steroid-induced remissions. And we have to be clear on that. They are not useful as induction agents. They can be useful in combination, as we'll discuss with TNFs, but they maintain steroid-induced remissions. And if you look at it from that perspective, I do believe they're useful.
Russ, are you using thiopurines in your practice?
Oh, absolutely. I mean, I think as Steve mentioned that there is a long history of using them by people who are very experienced with these diseases. It does not work well as an induction agent, but as a maintenance agent proven by patients who you're following up, you're scoping, and we have patients who are on them for decades without problems. And there are even studies showing that when you remove thiopurines from people who've been on from a long time, they relapse. There is also, we may talk about this a little later, but recent in February's Gastroenterology Journal, the UC Success trial showing patients with ulcerative colitis randomized to azathioprine or infliximab or the combination. The 16-week success rate with azathioprine and infliximab was comparable. The other role with azathioprine or 6-MP is in combination therapy with an anti-TNF agent. In the UC Success trial, they had double the efficacy with combination and as you know, decrease anti-drug antibodies.
And I'll just add that it was a steroid-free remission in that UC Success trial, which goes along with what Steve said. And in my experience as well, a patient who responds rapidly to steroids but may be steroid dependent or has needed them more than once in the year is somebody who I think is a good candidate to be on a thiopurine maintenance strategy. And I too am still using these therapies. Let's talk for a bit about anti-TNF therapies. As you both know, we now have 3 anti-TNF agents that have been approved for the treatment of moderate to severe ulcerative colitis: infliximab, adalimumab, and the newest one, golimumab. Tell me a little bit about how you're using these agents, in which patients. Do you select specific patients for specific agents? And you've already mentioned, Russ, that you are aware of the data that suggests that using them in combination with a concomitant immune modulator works better. So maybe you can start us off and tell us a little bit about your use of these drugs.
Well, I think that in most cases I do use them in combination. There is some suggestion that if you're just doing it to decrease immunogenicity, then perhaps you could use methotrexate instead of the purine analog. Talk about that if you want. But as far as the choice of the agents, the best data from the original clinical trials was with infliximab. However, the rates of adalimumab and golimumab were pretty comparable to the infliximab rates that were seen in the trial I just mentioned, the UC Success trial, which was just published in February, Gastroenterology. So I think that a lot of times the choice of agents is really going to depend upon the setting. If the patient's inpatient, they're most likely going to get the intravenous infliximab, but also by their insurance company. We really warn you against giving an anti-TNF and then having the insurance company say, no, we don't pay for that one, we'll pay for this other one, and then having to switch the patient. That can be quite disastrous. So you want to make sure that their insurance company will be able to support the one that you have chosen.
Steve, the infliximab is IV, adalimumab and golimumab are injectable therapies. Do you believe that the delivery system matters with these agents, or does it matter more which patients are receiving the drugs?
Well, as Russ alluded to, there are 2 indications. One is outpatients with more moderate to severe disease, and the second is in inpatients with very severe disease.
And we should point out that all the pivotal trials for these agents that led to their regulatory approval were in outpatients.
Exactly, and in that setting, they perform pretty similarly. We have never seen a head-to-head comparison, but across trials they look pretty similar in that moderate to severe disease not responding to conventional agents. I think most of us would agree that in an inpatient setting, we're moving towards the intravenous infliximab, and we're still learning a lot about these agents. There are several key points to them that we've learned over the years. First and foremost is that episodic therapy is not going to be useful. We need to maintain blood levels to prevent the development of immunogenicity, antibodies against these, as well as to prevent the disease from relapsing. So when we give treatment, we are giving both induction therapy and maintenance. Now, the induction is actually reducing levels of TNF in the body. And that's why the induction is high dosing, because there's more TNF. But as we're learning, as we're getting the disease under control, the maintenance schedule will be somewhat lower. But we still have to keep the patients well, and I'm sure you want to go into more details about that.
Well, you bring up a concept of sort of disease burden, but it also gets to the pharmacokinetics, which is they're inextricably linked, right? Because when the patient starts to get better, they may have less circulating TNF, but they also seem to have less clearance of drug, which is in fact tied to how much TNF there may be, et cetera, et cetera. But these are important questions, and I think this is a topic that our colleagues need to hear more about. How do you dose these drugs when the patient isn't responding? So let's start with a primary non-responder. when you give someone an anti-TNF agent, when do you decide that the drug is not working? And how do you approach that patient in terms of changing the dose, continuing on for some defined period of time, and what are you going to do in that situation? It's a common problem our colleagues face.
So let's divide it between the inpatient and the outpatient setting, and there's a lot more experience in outpatients. In the outpatient setting, all of these agents get an induction schedule. They're different between the agents. Usually you can assess the response after that induction schedule. And we expect that the patients will essentially have a clinical remission by that time, a cessation of their symptoms. We look at biochemical aspects. C-reactive protein in patients who have had elevated CRPs, we should see that go down. We should see it go down to normal quickly. And if it's still elevated, it means the drug's not having enough effect. Now, I think nowadays, and this is a moving target because we're talking about what we're doing today, which is different than what we did a few years ago. I would redose a patient to see if I can drive that CRP down even as an outpatient.
So just the practical detail of that. If we're talking about infliximab, which we have a little more experience with, you've loaded with 5 milligrams per kilogram. You've seen a response but not remission. Tell us what you do next.
I give them another dose. And that's in contrast to what I see being done frequently in practice, which is they bump the steroids. You're never going to figure out if it's going to work. I give an extra dose of the TNF to see if you get a further effect. And then if you do, make certain that you're continuing to dose enough to keep that biologic effect, if it's CRP, or clinical effect, if it's absence of symptoms.
My approach is similar, and without evidence, what I've been doing is my third loading dose, frankly with any of the agents, I will give a higher dose. So if they haven't done exceedingly well and they're really close to remission after their first 2.5 doses, really, I'm going to try to give them a higher dose going forward. And it's not proven. I'm not sure if I'm doing the right thing for my patient, but it has a similar concept.
Well, we just reanalyzed the ACCENT study, looking at what happens after the 3 induction doses at 14 weeks.
In Crohn's.
In Crohn's disease, but it reflects the same in ulcerative colitis. You're absolutely right. And what we found is that if patients had a normalization of CRP, and also if they had blood levels of the drug, they're going to do well in maintenance. But if CRP wasn't driven down, or if they had no levels, and they're probably, as you mentioned, directly related, they're not going to do well in maintenance and probably needed higher dosing to get them there.
Similar was seen with the ACT-1 trial. Week 14 infliximab level predicted the likelihood of remission at week 52. So early assessment can tell you what's going to happen later, and maybe this is going to guide us, but we don't necessarily know exactly what the level should be, or do we?
We don't know yet, but I think you should explain some of your experience in severe ulcerative colitis and what we've learned about losses into the feces.
Well, we've learned that one of the places the drug may be going, if it's not being mopped up by excess circulating TNF, is a protein loss in the stool. And this is not new. In the early 50s, they were studying catabolism in colitis patients, and they found that a lot of protein was being wasted even in moderately active colitis. So it's understandable to think that a protein-based therapy that's being delivered IV may be leaking into the stool. Or as I say to patients, they're getting a very expensive therapy that they're then flushing down the toilet. The other analogy that you may have used, and that I've borrowed, has been trying to fill a bathtub when the drain is open. And so there is a concept here that I think makes sense.
So as you mentioned then, albumin is a marker.
Yes.
In patients with ulcerative colitis who have a low albumin,
100%
you
agree.
know that they're going to have a leaky gut.
I agree with that entirely. What hasn't been shown yet, is whether you can get on top of it or not. Whether you can really get on top of these patients and whether we can get them under control by doing something to give more drug or to manipulate the pharmacokinetics in some other way.
Yeah. You know, one thing I wanted to mention, and you guys all kind of went over this to the levels, is also you want to make sure your patient doesn't have C. diff. So one of the most common reasons I see for failure is C. diff. CMV, even if they were tested before, patients who have come back to our hospital all of a sudden failing their anti-TNF, they have CMV in their bowel, that they actually have inflammation and where it's located. Look again with the scope. Severity, again, the sicker patient, severity disease, location, maybe they just have rectal disease now. Maybe you just need to be more aggressive there and not have to necessarily change all their medications. And I see this more with Crohn's and with ulcerative colitis, which is a little more mysterious disease. Sometimes the patients actually have a complete endoscopic response and they're still complaining of all their symptoms for another reason. And then you do have patients who simply just need surgery, although I think now that we're able to measure, at least research-wise, infliximab levels in the stool, we've been able to change our treatment of these patients in-house with giving them a second dose, a week with the third dose. Whether you need to double the dose or not, I think you could wonder, are you still dumping more into the stool, or is it better to give 5 milligrams per kilogram repeatedly rather than the 10 milligram dose, given the cost of the drug? It may make more sense to do that. I mean, I think we need to study that a little more.
So maybe an explanation or maybe a different definition to your question of how do you define a primary non-responder or even a secondary non-responder is someone who doesn't lower their CRP to an adequate dose of the drug.
I think when they have a CRP that's measurable, that is an excellent marker, and I would agree with you. And in fact, some have now looked at using CRP, delta CRP, or even with its limits, delta fecal calprotectin as predictors of response to TNF. So if you measured a stool protein that was very elevated in a sick patient and you gave them their anti-TNF therapy and it dropped by 50% by the second loading dose, you know you're on track for something that's going to work. So I think those types of approaches we can talk a little more about, but that would be very useful to our colleagues. What this has opened my eyes to has been the distinction between somebody who is not responding to therapy because of a primary mechanism failure as opposed to a primary pharmacokinetic or delivery or dosing issue. So that's a very important concept. So cyclosporine, let's shift topics for a minute here. And we obviously all have experience with it at our institution, but very few of our colleagues use it. Russ, is cyclosporine a dead therapy, or is there still a role for it?
Oh, I think clearly there's a role for cyclosporine in the hospitalized patient who's failing IV steroids with ulcerative colitis. I mean, these are the patients who you get the best response, maybe not the best response with cyclosporine, but the best response with cyclosporine compared to other therapies, even to infliximab. I personally have not found very strong evidence in my practice or even reading through the details of this, people who have published studies, that the IV steroid refractory ulcerative colitis patients are going to respond well to infliximab. I think that cyclosporine is clearly for this niche. Patients who are responding to IV steroids just can't maintain with oral, you can perhaps use the infliximab.
But out of fairness, there was a European trial where they randomized patients to cyclosporine or infliximab in those who were failing IV steroids, and both drugs seemed to have a similar efficacy defined as response and survival of the colon to discharge and then in follow-up. And actually what I've pointed out about that same study was that the safety was the same in both agents. So how do you interpret that in context of what you just said?
Well, there's also been studies that show that the lower doses of cyclosporine worked as well as the higher doses of cyclosporine. I mean, these things I have not seen replicated when you're actually taking care of patients like we do. We have a lot of patients that we've taken care of over the years with IV cyclosporine. We were not part of those studies. I can't comment specifically on the patient choice to go in. I did read them. They did seem to have failed, oral steroids initially to go on IV steroids. Some of the earlier trials really weren't that stringent.
So Steve, when you have a sick hospitalized patient, how do you make a choice between the agents?
So let me just add that the CICIF study that we described is a very reasonable study, and I think for the majority of people who are going to be listening to this discussion, it represents what goes on in the community. It's not necessarily the experience in a center like the University of Chicago or Mount Sinai or Cedars-Sinai where we see the most intensive patients. The patients who are hospitalized in Europe are not as sick as the patients we've hospitalized here in the US. We're treating many patients who would be considered severe ulcerative colitis, more than 6 bowel movements on an outpatient basis nowadays. So in my experience, and I've shared it with both of you because we've lived together for a long time, is that in the most severe cases, we think that I've seen cyclosporine work. And it may be because in the most severe patients, they're not getting enough infliximab.
Well, that was why I brought this topic up.
Yeah. It may be that we just need to give more and more.
It's been my thought that if we believe that protein-based therapies won't work when the colon is leaking protein, or as a surrogate, they may have a low albumin, then perhaps we should be thinking more often about a non-protein-based treatment option. And so that's why I wanted to hear how you guys were now thinking about this.
Well, certainly we've all treated, amongst the three of us, patients who did not respond to infliximab, who responded to cyclosporine. Not ready for prime time. We're not advocating that to the community physicians, but we recognize that.
We just published a case report with our fellows of a patient who had been receiving infliximab at 10 milligrams per kilogram and not responding, and had an undetectable infliximab level, and then was successfully induced with cyclosporine, and very importantly, maintained on azathioprine. So I think we have to remember that you need a maintenance strategy in those situations. Speaking of azathioprine, are you using concomitant therapy in all of your patients who need anti-TNF agents?
Well, the evidence shows the benefit, but that's still, the question becomes, is that 13% benefit worth it in all patients? And the answer is, of course not. There are circumstances where patients don't tolerate thiopurines. There are concerns, obviously, in young men because of a very rare risk, but of a devastating type of lymphoma. I think that if we understand how to use these drugs optimally with the high-dose induction and maintenance and maintaining drug levels, we may not need combination therapy. On the other hand, azathioprine, and as Russ alludes to, methotrexate, may be less expensive ways of raising levels from an economic standpoint.
We've seen that in rheumatology. They know that it decreases clearance, maybe by a separate mechanism than just preventing anti-drug antibodies. So there's a role for that. I have to say that in most of my patients, I'm using concomitant therapy when I start anti-TNF, but I don't necessarily leave them on it either. And as we're starting to appreciate more is that we talk a lot about anti-drug antibodies, but in fact, it's not a majority of our patients who will get them. It's a minority, and we're not quite where we need to be in terms of understanding who is at highest risk for those. But it's an interesting topic.
Yes, we do. We do know who's at highest risk. The people at highest risk are the patients who are getting episodic therapy.
Sure.
But that even includes maintenance, because we see all the time patients referred who are losing response before the 8 weeks of infliximab, or before the second week of adalimumab.
Well, that's what I call pseudo-episodic therapy.
It is, but it is episodic therapy because they're dropping their blood levels, and that's going to incite antibodies.
But it's unintentional, right? I would agree with that. And the other group that does form antibodies is the patient who developed them to their first drug. So especially in that patient, when you go to your second anti-TNF, you want to make sure you're protecting against those. So why don't we shift gears to some newer approaches. One of them has to do with the hot topic of mucosal healing, which in theory sounds good, but in practice is more difficult, and even something called treat to target. So Steve, tell us about treat to target and where we are with that concept.
Well, treat to target comes from other disease states where there is evidence that treating, for instance, to a blood pressure below a diastolic of 90 or maintaining a glucose control alters the long-term consequences of the disease. Strokes and heart attacks and hypertension, other complications in diabetes. In rheumatoid arthritis, there's also evidence that treating to a clinical remission or a low disease state prevents the joint damage or the progression of joint damage. So the concept, which is yet to be proven in IBD, in ulcerative colitis and Crohn's, is that if we can control the biology, the inflammation, we can prevent the long-term consequences. The best example to date in ulcerative colitis are studies that you've performed that demonstrate that if you maintain inflammation, if you maintain histologic healing, you get a lower risk of cancer. And I think that's a good concept of treating to target an ulcerative colitis. Other aspects would be treating the evidence that in individuals who have healing of the bowel have less surgeries, less hospitalizations, less flare-ups actually if you get histologic healing. So those are some of the concepts. But as you suggested, it's a great target, but we can't always get there.
Right. So in order to do this, we would need to know when to look, how often to look. And by look, I mean either look at the mucosa or come up with something that we believe is an appropriate surrogate of mucosal control, like the CRP you've mentioned. But we don't actually know that any of this will work. So what are you doing in your current clinical practices? Do you ever scope somebody who now feels well after you've started whatever therapy it might be? And if so, which patients are those? Russ?
Well, certainly I think that if you're in a situation where you're going to make a decision based upon the findings, then that's reasonable to do. When you say the patient feels well, but if you have hints maybe from biological markers, whether it be a CRP, which is not always that great, if you're going to do fecal calprotectins, elevated platelet count in IBD patients, some other idea that the patient may not be doing as well, I think that's certainly a time to look.
But the patient who says, I'm not bleeding, I'm feeling really well, is there ever a time you should take a look and adjust therapy, or is that not worth doing?
Well, sometimes if I scope someone who had pretty severe disease, and I'm pretty surprised how well they're feeling now, and I don't want them to progress with ulcerative colitis, then even if they're feeling well, I might look and see. But patients who really didn't have that bad a disease, they responded beautifully, and you say, are you perfect? They're having one stool formed, no running the bathroom, no other extraintestinal. I think it's a little hard at that point to convince someone to get a scope.
Well, you're implying that the risk of making a mistake is higher in that patient who had severe disease. In other words, they're at greater risk for ending up with a big problem if they're not getting there, as compared to the patient with milder disease who's now feeling well. If there's still something going on in that patient, it's not as risky.
Well, I'm also skeptical that the patients who have really bad disease have healed up things magically.
Have faith in our therapies, Russ. They work sometimes. Steve, what about you? Do you look?
I look at some point within the first year, but I don't look acutely. I certainly recognize that some of our colleagues are starting to do more rapid exams, but that needs to be explored from a cost-effectiveness standpoint as well.
Yeah, my general take on this has been, I discuss this with patients who I feel have a risk for problems, and I don't look unless we already know what we're going to do with either end of the results. Because I've learned that that's a problem if you haven't talked about it ahead of time. So we'll have to see where this is moving, and I know there's a lot of work going on. Let's talk for a minute about new therapies. So we have a couple new therapies that may be approved in the next year, and we have others that are on the way. So maybe we can start with vedolizumab, which is the alpha-4 beta-7 therapy that's targeting primarily the gut mucosa. Steve, tell us a little bit about that drug.
So we already know that inhibiting lymphocyte trafficking into the gut is helpful in Crohn's disease. We have a drug, natalizumab, that's been available and has been effective. And natalizumab in animal models of ulcerative colitis has also been effective. The problem, of course, with this agent is that there's a risk of progressive multifocal leukoencephalopathy because alpha-4 receptors are ubiquitous. It's recently been recognized, or over the past years, that alpha-4 beta-7 receptors are limited to the gut. And inhibition of alpha-4 beta-7, or beta-7 alone perhaps, does limit trafficking of lymphocytes into the mucosa in ulcerative colitis and Crohn's disease. And some recent large phase 3 studies have demonstrated benefits of vedolizumab, which inhibits the alpha-4 beta-7 integrin, in ulcerative colitis. Very good results in both induction and maintenance, and also positive but not as robust effects in Crohn's disease.
So given that we think this therapy will be confined or more selective to the bowel, is there a reason to suspect or think that this drug might be positioned in a different place in our algorithm, or should it just be something we use after patients are failing their TNF therapies?
Well, I'm a believer that any effective therapy should be used earlier. One of the issues is the clinical trials look at patients who are unresponsive to steroids, immunosuppressives, and/or anti-TNFs. But that's because of the uncertainties of the safety of the drug. Now that we know that and have experience with greater safety, I think we should be using vedolizumab and the anti-TNFs earlier in the disease. I don't know, Russ, what do you think?
Oh, absolutely. I think in natalizumab's case, in the case of natalizumab, we were talking about using that even before anti-TNFs because the safety data was so good until the progressive multifocal leukoencephalopathy data came out, which then shuttled it to the back. But the promise of these agents, not just in patients who anti-TNFs did not work, which is nice, but also in other patients is quite broad, and particularly in parts of the country or parts outside this country where there are higher rates of tuberculosis or other infections that may limit the use of anti-TNF agents. If the safety for vedolizumab stands up to what we know so far, this may be a very attractive option in those patients too.
So let's talk a bit for a moment about some other mechanisms or other therapies that we might look forward to in the near future. What would you want our audience to know about?
Well, obviously, ustekinumab is on the market for treating psoriasis. There have been studies in inflammatory bowel disease with have some efficacy. We anticipate needing higher doses. The nice thing is that since it's on the market, we are getting safety data as it's going along, and some of us have patients who happen to have both psoriasis and IBD and have had some experience in that.
Okay. Another monoclonal antibody therapy. Steve, what about other mechanisms?
Well, we did mention, again, the adhesion molecules, so there are studies looking at other inhibitors of either MAdCAM in the gut or beta-7. We've also learned from rheumatoid arthritis that Janus kinase, JAK inhibitors, can shut down inflammation at a more proximal step by inhibiting ultimately NF-kappa beta. And JAK inhibitors have had some good preliminary results in ulcerative colitis and are being explored. And there are a whole number of JAK inhibitors that are about to be explored in these diseases. They're not all the same. They inhibit many different downstream signaling mechanisms. So the current one that's being looked at, tofacitinib, in rheumatoid arthritis, does cause some anemia and elevated cholesterol, whether it's going to, and also infections. So whether it's going to be safe in the higher doses that Russ alluded to in inflammatory bowel disease, we look forward to the phase 3 studies.
And this is an oral therapy.
This is an oral therapy.
So that's another interesting part about that one. So we have some new therapies to look forward to. I think that we've covered a lot of ground during this webinar today. We've talked a little bit about the pearls regarding diagnosis and being accurate in our assessment, better use of some of our fundamental therapies like 5-ASAs, even some pearls about how to get people off steroids. And I think that the discussion we've had about biological agents, and specifically the anti-TNFs today, has really revealed some of how we're approaching the patient not responding in new ways. There are some new therapies to look forward to. I think that our patients will have more options than ever before, and I think our colleagues will have some better approaches for the future of their management. So thank you both for being here.